Everybody, and this week's case is an 11-year-old neutered male Cocker Spaniel presenting with acute progressive right pelvic limb lameness. So let's have a look at the MRI and see what that showed this week. So in this particular case, where lameness is the main presenting sign, um, it's really important that we assess all the structures. Obviously, lameness can be due to orthopedic disease, muscular disease, peripheral nerve disease, as well as disease involving the nerve roots. So with pelvic limb lameness in this case, we'll be particularly interested in assessing the intervertebral foramina of the L4 spinal nerves caudally. So we're most interested, or we need to critically evaluate the caudal lumbar spine, taking particular attention to look at the neuroforamina, muscles, etc. In these cases, often I personally would like a dorsal stir or fat suppressed T2 weighted image, which you don't have in this case. The reason being that when lameness is the main sign, the dorsal plane is a really nice study for assessing non-neurological structures such as the sacroiliac joints, hip, paravertebral muscles, etc. The dorsal plane for the lumbar spine, LS spine, is also great for assessment of the lumbar nerve roots. So there are some high resolution sequences such as the ProSet or CIS VS2C, which are great when it comes to assessing nerve roots in the LS spine if you have them available. So here we have the sagittal T2 and sagittal T1 weighted images. So we can see that the T2 weighted images show degeneration of all the intervertebral discs with a reduced signal intensity of the nucleus pulposus, not unexpected in an 11-year-old dog. There appears in the midline sagittal images that we have mild protrusions of multiple intervertebral discs, but the size of the protrusions themselves is quite mild. We don't really see any convincing signs of displacement or compression of the spinal cord or cauda equina. However, as we go off to the parasagittal images, we can see on the right-hand side that we have this abnormal intervertebral foramina at L6-7. So the sagittal T1 weighted images are a really nice sequence for assessment of the lumbosacral intervertebral foramina. The reason being that we can see very nicely attenuation of periradicular fat when we have foraminal stenosis. So in this particular study, we can see that there appears to be a small nodule of low signal on both sequences, tissue which is extending or adjacent to the L6, L7 intervertebral disc and appearing to extend into the right-sided intervertebral foramina. Additionally, we have the L5-6 disc space. We can see that lateral to the disc space itself, there appears to be this tissue extending laterally, which almost contacts the right transverse process of L6. So we can see on the parasagittal images here that we have the normal lumbar nerves which run within the psoas muscles, and we can see that adjacent to the nerves themselves we normally would see this fat which runs adjacent to the nerves themselves. So this parasagittal image can be quite nice when we have pathology within the nerve roots of the lumbar nerves running through the psoas. Sometimes we'll see swelling or attenuation of this normal fat signal. So in this particular case, we can see the nerve root itself, and we have this possible impingement between this tissue and the transverse process of L5. So if we have a look at the transverse plane images, so here we have the transverse T1 and the transverse T2 weighted images through the L6-7 intervertebral disc space. So we can see very nicely on the transverse plane images that we have this quite severe foraminal stenosis on the right at L6-7. So we see very nicely on the T1 weighted image here, this is the normal appearance to the intervertebral foramina, where we have in this case the L6 nerve with the normal periradicular fat. And on the contralateral side, we can see that we have this nodule of low signal, relatively homogeneous, smoothly marginated tissue, which is filling or largely filling the intervertebral foramina. So as we scroll back and forth, we can see that this is the right L6 nerve roots. which are paired, obviously the dorsal ventral roots. And as we go into the foramina, we can see that we have this displacement dorsally and a degree of effacement of the nerves themselves. As we follow the nerve ventrolateral after it exits the intervertebral foramina, we can see here the L6 nerve, that we get the impression that there's mild swelling of the nerve compared to the contralateral side. The T2 weighted images doesn't show any signal alterations, although often with nerve root compression, we will expect to see some hyperintensity within the affected nerve. So we have a 3D turbo field echo sequence in this case, which is a very nice sequence for evaluating the lumbar nerve roots. So with 3D acquisitions, we can reformat them into different multiple planes as you do on CT, and that can be very helpful when it comes to following nerve roots, etc. So here we have the dorsal plane reconstruction, and we can see very nicely at L6-7 on the right that we can see here the L6 nerve is being severely compressed by this nodule of low signal tissue extending dorsally from the disc space. If we look at the sagittal plane images, we can see very nicely this nodule of low signal disc material extending craniodorsally from the disc space. So additionally, if we go slightly cranially, we can look at the L5-6 disc space. We can see that we have this lateralized tissue, which appears most likely to be spondylosis, and we can see that the L5 nerve here is possibly impinged between the transverse process of L6 and this new bone formation here extending laterally from the disc space. So in this particular case, we do have a stir image in the sagittal plane, and this shows very nicely the value of the stir sequence when it comes to evaluating spinal disease. So if we have a look at the hypaxial muscles, we can see that there are these areas of patchy T2 hyperintensity, which we see very nicely on the fat suppressed sequence, which are visible on the T2, but very difficult to appreciate. It's quite difficult on the T2 or impossible to differentiate fat within muscle from causes of high signal such as edema or myositis. Additionally, in this particular case, we can see that there's an abnormal appearance to the right L6 nerve. So here we can see the nerve or perineural tissues are swollen and increase in signal on the T2 weighted images. So we compare this nerve with the ones more cranially and also with the contralateral side. We can see quite nicely the difference between the right and left L6 nerves. So in conclusion, the MRI shows the presence of low signal extradural tissue within the right L6-7 intervertebral foramina, which appears to be extending from the disc space and causing severe compression of the right L6 nerve, which would explain the lameness. We also have possible entrapment of the right L5 nerve, most likely by lateralized spondylosis deformans, or less likely a lateral disc extrusion. So in terms of differentials, the changes at L6-7 are most consistent with an acute right-sided L6-7 foraminal disc extrusion. And this is something which we see not that uncommonly. It can be quite subtle, and this is a really nice example showing that the sagittal images can underestimate the severity of peripheral nerve compression and why we require multiple planes. We also have possible entrapment of the L5 nerve by spondylosis deformans. This will sometimes see causing clinical signs, often with these cases where we suspect nerve root entrapment. Post-contrast images can be helpful because sometimes we'll see abnormal enhancement of the nerve or the perineural tissue. So we need to be a bit careful about not over-interpreting that, so that would require correlation with the clinical findings. So hopefully you found that case interesting, and we shall look forward to seeing the outcome from ELSA later in the week.